Welcome back to the Sports Medicine Orthopod. My name is Anthony Yu, and I'm joined by my good friend, foot and ankle specialist from Loyola, Dr. Adam Schiff, who we always seem to have on around March Madness time. I'm wearing my UCLA gear. I am a Loyola and UCLA alumnus, but I'm going to claim UCLA tonight. Pac-10, Pac-12 tournaments going on. How are the Loyola Ramblers doing, Adam?
The Ramblers are doing great. We are sitting pretty. This is an off week. We had our conference championship last weekend, a little closer in the end than we wanted, but back-to-back tournament bids. And this is just a week to watch, get ready, hopefully see some upsets, and
right.
hopefully Duke pulls it out this year also.
Yeah. That's right. You got split allegiances as well.
Absolutely.
Wanted to bring you on to talk about this month's interesting injury, which is award goes to Joe Harris, the shooting guard for the Brooklyn Nets. So the story on Joe Harris is he had ankle surgery at the end of November during this season. Report is he had an arthroscopy. He got scoped for what was described as a loose fragment in his ankle that was removed. The estimated timetable for him to return was 48 weeks, which came and went. And he did not have a smooth rehab process. Anybody who follows his career or the Nets knows that he had some setbacks, continued pain. There was a report that he might have to have another surgery, which would end his season. There was another report that he might just try to play through pain. He's an important part of the Nets' plans and their playoff run that they hope will end in a title. And it was just announced last week that he's going to have that other surgery, that second surgery. And so his season's going to come to an end. And so I wanted to bring the foot and ankle specialist on to dissect this. Now, we're reading through the tea leaves a little bit because the reporting has not been much more specific than that. And we don't like to wildly speculate on this show. And so we'll just, paint this with a broad brush and sort of general concepts, because a lot is left out in the details, but which would really flush out the picture here. We just don't know those details. But Adam, let me get your take on it from a general perspective. What were you thinking about when you heard this story?
Yeah, I mean, certainly interesting, either an interesting problem or an interesting treatment of a problem. As we've talked about before, these elite athletes, NBA players, get treated a little bit differently. Some things that for you or I or the lay person, we wouldn't want to go undergo two surgeries in 2 or 3 months. We want one surgery and want to be done. Certainly, they may have been trying to take a shortcut just to get him back for the season, knowing there's a lot on the line. NBA season's up for grabs. So it's a little hard to say if this is an unusual injury or just an unusual treatment path. But obviously, a few things come to mind, right? At his first injury in November, story from the team comes out. It says he has a tiny bone particle, and that was causing symptoms, and he's going to have this arthroscopic surgery to treat that. So initially, a few diagnoses come to mind. First, we think, of course, osteochondral lesion. So a piece of cartilage breaks off. It's kind of floating around. Someone who has an osteochondral lesion like that might experience sort of symptoms of a loose body, catching or popping, right? This piece pops in and out of the joint. It causes a mechanical symptom. It feels like the ankle's going to give out. It hurts. It may recover, it may not. And so that certainly could have just been a remove that loose body and clean it out. And that's definitely something with the timetable that would match. Also, having a loose body could be a ligament injury, right? The ligaments connect bones to bones, and sometimes those ligaments tear. It rips a little piece of bone off, an avulsion fracture. And depending on which ligament that is, that piece of bone could be very symptomatic for somebody. And that could be sitting in his joint or around his joint, particularly off the medial side, the medial malleolus. It's a big, strong ligament there. That could be symptomatic, and that could have been his removal. And then lastly, a little bit of an outlier could be something we call an osteotrigonum. An osteotrigonum is a piece of bone in the back of the ankle. It's normally, the tails is normally one bone, but some people it doesn't attach completely, it doesn't fuse completely. You have a small piece of bone back there that's held together with really strong ligaments. And an injury can cause that to separate. And you've got a piece of bone that's an irritant and causing inflammation. And that can be removed either open or arthroscopically. And so I think one of those three is the most likely course of events for what happened. All would give you a timetable of being out 4 to 8 weeks. All would hopefully get you back this season and get him back to play well enough to keep the net season going deep into the playoffs. As you know, obviously that's not what ended up happening.
Yeah, and to further your point, joints typically don't like loose bodies. Now, larger joints like the shoulder, the hip, the knee, they may tolerate some small ones. Loose bodies in the knee are very common, especially as somebody may develop arthritis. And arthritis is basically the wearing away of the cartilage that you had mentioned. And so you might get these little tiny flecks of cartilage that flow throughout the knee, and you would never know it. But if the loose body is sizable enough, and we're talking, maybe if 5 to 10 millimeters, a centimeter or so, maybe 1 to 2 centimeters, not very big in the grand scheme of things, but joints typically don't tolerate that well. They cause, as you said, mechanical symptoms. They cause inflammation, swelling, and pain. Ankle is a tiny joint, and you can imagine that a small particle probably would not be tolerated that well in a joint like the ankle, which is much smaller than the knee.
Yeah, absolutely right. And when you have a loose body or have these symptoms of catching and popping and locking, the easy thing or the simple thing to do is to immobilize it, put it in a boot, put in a brace, try to let the inflammation calm down. And while you have the ankle in a brace, that loose body is probably not symptomatic. Well, that's not playing at an NBA level. It's not playing elite sports. And so
Sure.
the moment you try to go back to those activities, cutting, pivoting, jumping, landing, it's going to cause that joint to become irritated and catch and pop very easily. So, for a normal person, they might not feel these loose bodies. For what Joe Harris is doing on a daily basis, it's going to be very symptomatic.
Yeah, and so let's fast forward to what we learn now, and that is a second surgery is coming. And I think probably to the layperson, your instant thought is, oh, that first surgery maybe was wrong or was erroneous or, clearly didn't work. And so let's kind of pull back the curtain on, our perspective on that as surgeons. Obviously we're trying to do right by the patient, whether they're Joe Harris or Joe Blow, whoever, we want to do the right surgery for them. But as you had mentioned, in these professional athletes, the calculus is a little bit different than the weekend warrior, and trying to get him back to play some meaningful minutes in the season, especially this season for the Nets, is of the utmost importance. And so I think that's one possibility you alluded to, right? That with an arthroscopic surgery, it's minimally invasive. You're putting a tiny camera into the joint through a tiny incision. You make one other tiny incision where you place some instruments in that the tools you need to remove that loose body. And so the footprint you leave is very small. And we do this for shoulders and knees. That's what I do all the time. You do this for ankles. And so, as you alluded to, as I was saying, that's one possibility, right? Like, we're going to try to go in with a minimally invasive surgery that's not going to be sort of big exposure with, exposing the patient to big risks, and therefore thinking maybe the downtime afterwards is going to be pretty extensive. And sometimes that works and sometimes it doesn't, right?
Yeah, that's absolutely the case. I mean, this goes back to what we call shared medical decision making, right? It is not us making a decision. We try to work with our patients and their families on what is the right option. And when you have a professional athlete like this, that extended family is much larger. We're trying to make decisions what's in the best interest of the athlete, the team, the fans, the agent. I mean, all of those people are sort of weighing in, and it's a little bit more complicated. Sometimes we treat just the symptoms. Can you make someone feel better to get them back to that activity? And in the case of Joe Harris, it's can you get back to playing at a high level? Other times you treat the cause of the symptoms to prevent it from ever coming back again. And mid-season, sometimes you take that, I'm just going to do a smaller surgery for a smaller recovery, knowing that it's not solving the problem, but hoping that we can get away with doing less in the short term, right? So short-term benefit, but not long-term benefit. For a lot of our normal patients, You don't have the luxury of, I'm doing surgery now and I can do another surgery later. It's let's do one and be done, and let's do it all right the first time, and let's do one recovery. But for some people, it really is best to sort of do a smaller surgery now and a larger surgery later. That's probably what happened with Joe Harris. It's not that there was ever a mistake or that something was missed or that, he had a complication. Those do happen from time to time, but this is more likely a let's try to get away with something smaller. If we can, great. If we can't, you're out the season anyway. If we do something big now, the season's over. If we do something small, it doesn't work, well, the season's over. So probably this is a result of trying something smaller, and then it didn't work, unfortunately, for Joe Harris and his team and fans. And now we got to do something bigger where you still expect 100% recovery by next year. And it's frustrating to see anyone go through multiple operations. It's frustrating as a fan of the team. It's frustrating for Joe Harris. It's frustrating for his doctors, I'm sure, to have to do this again. But, it sounds like this was not a mistake. It was something that was a distinct possibility. And unfortunately, that's what ended up happening.
Yeah. And so to run through some of those possibilities you had laid out earlier, just briefly to give the audience an idea of what we mean. So let's say it was an osteochondral loose body. So a piece of cartilage, maybe with some bone attached, had broken off from some sort of injury, was floating around. That was a loose body. It gets plucked out. Well, there's a defect actually in the bone, right? There's a piece of cartilage missing. There may be some bone that's missing as well. And that in itself could be symptomatic. Bone doesn't like to be uncovered. That's why arthritis hurts. It's not because the cartilage itself that's wearing away is hurting you. It's because the bone underneath there has lost its cushion, and it does not like that. That causes pain and inflammation. And so, again, we don't know this to be the case, but let's just go down this hypothetical road. Let's say that was the diagnosis. They took the loose body out. He's still symptomatic because the bone in the ankle joint is feeling the effects of losing its covering cartilage. It has pain. It's causing inflammation, swelling, etc. And so, a more not necessarily invasive surgery, but one that would certainly have a much longer recovery would be to try to do something to fill in that defect or to sort of stimulate regrowth of cartilage to fill in that pothole.
Yeah, that's absolutely right. It's, step one is remove the loose body, and step two is actually fill it in and try to get it to heal. You use the term that I like so much in describing things as a pothole, right? If you think of a nice fresh paved road, if you've got a pothole, if it's small and your tire drives over it, you don't feel that. But if it's big enough that your wheel's hitting into that pothole each time, it's going to be a big bump each time. And so that loose body is that loose gravel. So the first thing is just clean it out and make it nice and fresh. But if that ultimately is not relieving symptoms, you still have pain from it, you got to actually fill that pothole in and make it smooth again. And so that would be exactly right. You go in, you try to either bring up, fill the bone in, try to bring up cartilage, microfracture it, bring the stem cells from that up, or even potentially grafting it, bringing cartilage in from an outside source, whether it's a cadaver or a product that you can purchase, or you take it from your knee joint or whatever, trying to fill that pothole of bone and cartilage in so you don't have that problem going forward. Much more extensive surgery, much longer recovery, much more healing. It can be done still arthroscopically. It just, you have to let the bone and the cartilage heal as opposed to just removing it where you just have to let the inflammation calm down. So a much longer recovery, and it would be expected to be out, a good 3-4 months before he's back running, and probably 5 months or so for competitive play. Best case scenario, that's looking at the beginning of the season anyway for next year. So that certainly puts you in the time frame that they're discussing.
Yeah, absolutely. And so, I see these types of injuries in the knee all the time. And you mentioned there's 3 or 4 different possibilities to try to basically fill in that pothole with something, new bone, new cartilage, whatnot. Basically, again, trying to smooth out that surface by, inducing some healing or replacing it with a graft. In our world, and I think this is probably true of all medical specialties, when you've got 5 or 6 options for the same injury, it means none of them are that fantastic. And so that also lends itself to a lengthy recovery, because these repairs, whatever we're doing, reconstructions, what have you, they can be fragile. And so you're definitely going to hold somebody to a long recovery to try to maximize the chances that it works. We just have not figured that one out in terms of a gold standard way to fix osteochondral lesion, really in any joint.
Yeah, that's absolutely right. I mean, there's just so many factors in it. The size, the location, the types of stress we see. You see different stresses in the knee than in the ankle. And so a graft or a product that works in the knee may or may not work in the ankle. There's no great answer. And everyone has theories and algorithms, but we just don't know what the right answer is. And Joe Harris needs a lot more out of his ankle than the average person does in terms of range of motion and impact. So you never know what that right option is going to be or what it's going to be. Cartilage is precious. You get it once, you're born with it, or it develops, and that's it. You don't get it that same stuff anymore. And trying to chase down new cartilage is like the fountain of youth.
Yeah. So if any of our audience members can come up with a way to regrow cartilage, you direct message us and we will split the money with you.
Yeah, we'll do the Nobel Prize with you. You can come on stage with us. But yeah, no, I mean, that is, I think, people have got theories, and there's lots of these stem cell clinics popping up and these types of injections. But as you know, nothing's been proven to work, and those aren't even FDA approved. But anytime someone thinks they have the answer, it's never been shown to have the answer, unfortunately.
Yeah. The holy grail of orthopedics. Okay, so we went down the osteochondral lesion rabbit hole a little bit. Let's briefly touch on the other one that you mentioned, which would avulsion fracture, ankle sprain, took a piece of bone with it. That's symptomatic in the joint. It gets removed. And so sort of the long surgery would be if the ankle's unstable because of this sprain that resulted in the avulsion fracture. You took care of the bony fragment, but didn't address maybe the underlying problem, which you had mentioned, which would be ankle instability.
That's absolutely right. So you have an avulsion fracture, the bone breaks off, you remove the bone, but the underlying problem is instability. And so this time you would go in and you'd repair and you'd fix the ligaments. That's often, it can be done in times arthroscopically. It's not often arthroscopic. Maybe you need the arthroscopy to diagnose the instability. That's a really high possibility and high likelihood here. You don't make it to this level in the NBA or into most sports without having ankle instability, rolling your ankles. And so if you MRI virtually any NBA player, you're going to find chronic ligament injuries. It'll be, you'll see tearing or scar tissue within the lateral and medial ankle ligaments. And so you have an athlete like this who has an MRI and has maybe a loose body or has avulsion. Well, you're looking at it and you're saying, well, I don't know if these sprains are acute, new, fresh, or these are just chronic. They've always been there. And so you could see very easily try to treat the symptoms, saying, well, you made the NBA, you've probably sprained your ankle 100 times before you made it here.
Sure.
So our MRI saying you have ligament tears. Yeah, we probably know you have ligament tears. It's probably there before the season ever started. So treat your piece of bone that broke off, expect the ligaments to return to baseline. Well, in this case, maybe not. Maybe he was still unstable or he developed instability even though he had these chronic ligament tears previously. So, that would be another great reason why you try the small surgery first, but not the big one. But you wouldn't necessarily do that for somebody else who would not have the history of ankle sprains that Joe Harris has. So
sure.
A ligament reconstruction, a much bigger operation, depending on what ligament, it's going to be crutches for 4 to 6 weeks and no walking on it for 6 weeks. And then a walking boot and working on range of motion and, a long time till they're back playing competitively, good 4 months, 5 months till running, 6 months to competitive play. Again, puts you in time frame to likely be 100% before next season.
Yeah, I think door number 3, I just wanted to touch on briefly, which was you mentioned the os trigonum, which in many people are not symptomatic. And so this is not an admission of guilt as an orthopedic surgeon, but this is just to say that sometimes we don't always have the answers, particularly on the first go around. We collect evidence. We may even do things to challenge certain parts of the body to see if we can narrow down where the pathology is coming from. And so say, for example, my ankle's hurting. We don't really know why. I've got an ostrigonum, an extra piece of maybe like a piece of bone that on the talus that didn't fuse. We want to put it to the test. Maybe we inject the joint, see how it goes, and then I get better. And for lack of other pathology, we think, okay, this is it. We go in to do the surgery, take the osteogonum out, and I still have pain. And then we find out later, okay, it was something else. And this doesn't happen that often, but I wouldn't say it's like totally out of the blue. Most of the time in orthopedics, 80, 90% of the time, we got the diagnosis. We know exactly why somebody's having pain, swelling, instability. ACL tear, we know that's why your knee is unstable. Slam dunk every time. But sometimes it's more mysterious, and it's not as straightforward. And so, like we said, we call the evidence. We make educated, not guesses, but we put everything together to formulate what we think is the best possible source of the pain. And then we go address that. And most of the time that works, but not all the time.
Yeah, it's absolutely right. I mean, this is the art of medicine, and there's some things that are not obvious. And in someone like this, or someone with a history of his, it's very confounding. There's not a normal MRI. It's going to show a lot of abnormalities. And so you try to figure out, well, which of these abnormalities is causing symptoms, or which is causing the reason he can't play. And you're absolutely right. I mean, things like osteogonums, you can do things like injections to try to narrow that down. You get a lot better from that injection, and you could say, well, with a lot of reasonable certainty, 80, 90% likelihood, this is what's causing symptoms. This is going to take care of it. But it doesn't mean it's 100% going to take care of it.
Right.
And maybe it makes him so much better, but not all the way better. And to play at this level, you really need to be all the way there. So
yeah,
these things are absolutely confounding. It's never straightforward. And this is why there's always discussions with patients, and why we don't just rush people's surgery the first time. We try to get information, and then sometimes we need to get more information. And these are never straightforward answers, unfortunately.
Yeah, and if you've ever had a surgery of any kind, you see that long consent form. The nurse hands it to you before you have the surgery. Nobody reads it because it's like 5 pages long and it's all fine print. But written in there somewhere is there's no guarantee this is going to work. Probably in a very confusing language, but that's essentially what it's saying. And
that's absolutely right. I mean, the only guarantees are death and taxes, and
right.
You got to stack the deck as much as you can. Some things you have to have surgery for, right? You tear your ACL and you're unstable. I mean, your options are wear a brace or have a surgery to repair it. There's not a lot in between. You break a bone, if you want to heal the right way, sometimes those bones need to be fixed with an operation. It doesn't mean that you're going to have 100% perfectly great result, but it's going to restore things the best you can. And that's an example with Joe Harris's ankle, is that, he had an injury and he underwent a surgery with the hopes of restoring it as best he could. Unfortunately, it didn't restore it to the level that he needed, and he had another operation for it. These are tough situations and tough problems, and no fault of anyone's out there. And it sounds like everyone's really much on the same page. A lot of times we as fans hear about stories of our athletes because there's dissatisfaction. They're not happy. They go to the media, they complain, and not just the athlete, but the physicians, the agents, whomever is unhappy. It sounds like everyone in this situation was on the same page. They tried an operation, they tried to get better, and unfortunately it didn't work. And everyone's okay, well, now he's having this operation, and no fault of anyone. So far, you got to expect that this was handled the right way and the right decisions were made. That's why no one's unhappy. The expectations were probably set very well, and you just got to commend whomever took care of him. They probably did a great job with those discussions.
Yeah, and of course, the Brooklyn Nets are going to have top minds in the orthopedic world helping the team, and of course, Joe Harris has access to any orthopedic doctor he wants in the world. So he's getting the best of the best. And sometimes, it just chips don't fall in your favor. We see this with the shoulder all the time in terms of that, multiple areas of multiple spots in the shoulder that could cause pain. trying to identify which one is the one that's causing the majority of the pain can be really challenging. So, we see these kind of diagnostic dilemmas all the time. And like you said, most of the time we get it right, but not all the time.
And to your point, exactly, just because there's a lot of pathology and a lot of things that aren't normal, you don't necessarily want to fix them all.
Right.
At some point, you could go after every single thing that wasn't right and do more damage by starting to treat things that aren't there. And so, it really does require a good, trustworthy partner to make these decisions for you. This is a little bit of a broader topic, but this is what I always tell patients when they go to choose surgeons, or especially in areas where they can get second opinions, which are great sometimes to have second opinions and have other people weigh in. Is a lot of people can do your surgery right, but very rarely is it just straightforward. I'm going to make a decision and fix it. There's a lot of decisions that get made, and you just have to trust the person that's doing your surgery that they're going to make the right decisions for you. It's the decision making is hard about surgery. It's not necessarily the technical aspect most of the time.
Sure. All right, Adam. Well, great to see you. I will be rooting for both the Bruins and the Ramblers until they play each other, and then it's going to be UCLA. How you feeling about the tournament?
I'm excited. This looks like it might be the most normal or most back to normal tournament in a while.
Yeah.
It'll be nice. I mean, just think 2 years ago, this is when the tournament got canceled.
Yeah.
So thrilled to have the tournament back. It's good to have some competitive play. Thankfully, baseball worked out a deal, and so we can get another professional sport to look forward to. And I think the most exciting thing of the spring is apparently Deion Sanders is going to challenge people to races. The toeless Deion.
Prime time. Not quite in his prime anymore, unfortunately.
No.
All right. Adam, great catching up with you. Good to see you.
You too. Always good to see you.
All right.
Go Ramblers.
Yeah, that's right. Go Bruins. Take it easy. Have a good night. Hey, folks. Thanks for tuning in. If you like the show, please subscribe, like, and share. And we love to hear from you. If you have a question about today's show, or you, a loved one, or maybe your favorite athlete has sustained a sports medicine injury that you would like to know more about, please reach out to us on Twitter, Instagram, Facebook, or email. And stay tuned for more exciting content from the Sports Medicine Orthopod. Thanks again.